All right. Well, welcome everyone. We are so glad you are here tonight. We're really looking forward to going over fibroids and other similar issues that occur in the uterus and what treatment options can look like. So I am pleased to introduce our presenter tonight. It's Dr. Jeffrey Conaway. Dr. Conaway is a highly experienced physician specializing in minimally invasive image-guided treatments. And he has helped many women find relief from fibroid symptoms. And he's passionate about making sure patients fully understand all their options before making a decision. So we're really excited to have him. We are going to spend the next 20 minutes or so going over content. And then if you have any questions throughout, please drop it in the Q&A box. And then Dr. Conaway will answer those at the end. So I will turn it over to him.
Thank you. Thanks for that kind introduction. And thanks everybody for joining in tonight. We're going to go through things. And, I understand that some of you are going to be coming from a place where you might already have a diagnosis and you're looking for treatment options. And some of you are just dealing with symptoms and you're not sure what's going on. And is this what's happening to me? So we're going to go through a variety of things that hopefully you'll find interesting and informative, no matter which way you're approaching this and where you're coming from. So let's just jump right in, and we're going to go to the next slide and kind of introduce what uterine fibroids are. They're benign tumors that affect the uterus in women, and as women age, they're likely to affect or be present in a huge majority of women. Depending on what study you look at, 80 to 85% of all women will have fibroids. That doesn't mean that they're all affected by their fibroids, but some women certainly are. And those are the ones that we're really going to be reaching out to with this kind of information tonight. They're benign tumors, as I mentioned. They are hormonally stimulated by progesterone and also estrogen. And we know that because we find hormone receptors on these tumors. They come from the uterus muscle tissue and they grow in a ball-like shape. And they are stimulated so that you see that they show up in later age because they're stimulated by the hormones. They're growing through the reproductive years on into the perimenopausal time frame, where the hormones aren't affecting them as much. Then we don't see them be quite as much problem. But if they have grown quite large, then I do see a number of women that are in early menopause that may still be suffering from the effects of fibroids. It doesn't really matter, even though this touches upon some ethnicity relationships that fibroids have. I'll see all races affected. In fact, one of the patients that I had that was Scandinavian ethnicity had the second largest set of fibroids I've ever seen. And so just because it may affect some ethnicities more than others, we'll see them in all races because it affects a huge number of women. And so, just like other diseases might have preferences for some ethnicities, like osteoporosis, we'll see all races get affected by those things as well. Next slide. So, how do these benign tumors still cause you problems? Well, they present in all kinds of symptoms, but one of the most common and frequent complaints that they cause is heavy menses. And this can be not just irregular menses, because women can have normal length of menses, but really, really heavy menses. What does that mean? Well, it means going through lots of products, especially in these heavy days. It can be so much bleeding that it can cause anemia, which you see at the bottom of the list. And it can result in very large blood clots that are being passed. And so these are the things that we kind of start to look for, extending beyond 7 days, even having more than one menses in a month. So these are some of the things that we're looking for when we're looking for symptoms or signs of uterine fibroids. Um, there's different kinds of pain that can be associated with fibroids, and that can be cyclical, either before menstruation starts, but really intense pain during menses, and even off-cycle pain. And that can be caused from just the fibroid being really bulky and causing chronic pressure and pain throughout the whole time period, even off-cycle. Um, uh, Other symptoms that you see on this list are really what we call bulk symptoms. They're related to the fibroids growing so large in the uterus that it's causing pressure and mass effects in the pelvis by pushing on the bladder. So, as in antegrade uteruses where they bend forward in the pelvis, they are pushing on the bladder, and the fibroids are enlarging that and causing urinary frequency, urinary urgency, having to get up multiple times during the night to empty your bladder. Um, and then if the uterus is more retrograde or the fibroids are posterior located, then they can push on the colon or rectum, causing constipation. Um, the They also, because of mass effects, can irritate intestines. They can cause intestinal upset, bloating. As the uterus gets so big, it can cause just pressure. Deep pelvic pressure is what lots of patients will talk about. Also, it pushes on the vagina and can cause pain during intercourse or after intercourse, tenderness after intercourse. And so these are a lot of the symptoms that we will see with what we call the bulk symptoms from the fibroids taking up so much space and enlarging the uterus. And it can cause even things that you might not think about, like lower abdominal discomfort, especially as the uterus gets really large from the fibroids. So, patients that will talk about trouble doing activities that they really enjoy, like bike riding or horseback riding, where they're bending forward, and it's causing lots of pain because there's mass effect from the fibroids being up into the lower abdomen. And so we'll see a whole variety of different kinds of symptoms that we're looking for to try to identify that fibroids might be the answer to the things that are troubling you. Anemia, of course, anemia, because your body is not keeping up with all the blood loss from the heavy menses, then you can get fatigue, you can get dizziness, especially like if you're getting up because of the low blood counts. And so those are the things that we're talking about when we talk about the iron deficiency anemia. Next slide. There are other processes that can be very similar that can affect the uterus. And sometimes some of the other clinicians don't think about this because for especially like the gynecologist, adenomyosis or fibroids, they often aren't as worried about distinguishing these because they're going to offer hysterectomy as the solution. And so they may not care as much about distinguishing them, but I do care because they are treated a little bit differently when I'm offering treatments for these. But the symptoms can be almost exactly the same. What is adenomyosis? Well, the endometrial lining starts to grow into the uterine muscle. There is a similar process that some of you are probably familiar with or have heard about called endometriosis. And that's where the endometrial lining has gotten outside of the uterus into the abdominal cavity and is causing all kinds of symptoms there. But in this case, the endometrial tissues are growing into the uterine muscle, and it can cause many of the same symptoms. That tissue is stimulated by the hormones as well. And so it can often seem very much like fibroids, and the symptoms are incredibly well overlapping. So let's go to the next slide. So you'll see these same exact symptoms, really heavy menses, abnormal menses. What I will tell you is that these patients will often talk about pain really forward in their description of what's going on with them. And that is because the endometrial tissue, as it gets stimulated by the hormones, it's within the muscle, and it's trying to act like endometrial tissue, but in the muscle, and it's very painful. And so patients will really, really kind of focus on their descriptions that are very oriented towards their descriptions of pain. So we really look for those kinds of things. And when I hear those kinds of things, I really start thinking about adenomyosis when I'm working up patients. Next slide. So, how do we start to think about treating these kinds of conditions? Well, when the symptoms are mild, we will try to do medications, and they can often help mitigate the problems that are associated with fibroids or adenomyosis, although less so for adenomyosis, but they can be helpful. So, TXA can help control the bleeding for both, and the hormones can affect adenomyosis as well. So early on, when the symptoms are more mild, these strategies can be very effective. Usually by the time I'm meeting my patients, they will have tried some of these and they will no longer be helping them, and they're looking for other strategies. But early on, we might try these. I'm usually not involved with that as much because my patients usually have gone beyond that period where they're in the more moderate intensity or the severe intensity of symptoms, and they're needing treatments that are invasive. And so let's talk about those. Yeah, you know, if you've been diagnosed with these things, almost surely somebody's going to offer you a hysterectomy. And this is not just me talking about this. There are journalists out there. It's not hard to find articles talking about how, health insurance companies um, are not always looking to cut costs, but pass cost on. So they're not always looking to try to get you out of the most costly healthcare choices. We see articles about healthcare systems um, where surgeries are often promoted, and that's because they're big dollar items that make healthcare systems look profitable. Administrators may get bonuses, and journalists will talk about this because they have gotten so many surgeries because they're big ticket items, and so there are studies suggesting that these are overutilized. Well, most of the time when we talk about healthcare, we're talking about doing the lowest level of strategy that is effective. And so we want to start with medications first, and then start moving towards minimally invasive surgical treatments, and then the bigger surgical options last. Sometimes in patients, they get jumped right to the most extreme surgical option available, which is hysterectomy. These are not, necessarily benign treatments. If you look at the American Health Association, they have literature that is on heart.org that's talking about ovarian sparing hysterectomy increases significantly the risk for metabolic syndrome, for cardiovascular risks for women. And these are supposed to be the ones that are safer because they're sparing your ovaries. So these are not necessarily benign. I'm not saying that they're bad, because they definitely have their role in the treatment of patients. But maybe we shouldn't be jumping to those right off the bat. But we see these offered all the time for patients as it's either medications, deal with it, or hysterectomy. And there's a lot more options out there. So let's talk about some of those. So myomectomy is one of these that's minimally invasive, and I think really that although there can be significant complications and risk from these, where they're really great is in preserving fertility for certain kinds of fibroids. They can be really good. There are and we don't want to get into a rabbit hole of talking about classification of fibroids, but there are classifications of fibroids and where they're located. And there are ones that you might think of as like a cherry. They hang down into the endometrial cavity and they have a stem that connects them up to the muscular wall. And those are great for hysteroscopic myomectomy, where they put a scope inside the uterus and they can just cut that little stem and pull it out. And those can be really good, but those are not the most common kind of fibroids. Those are really uncommon. And there are some subserosal fibroids that are located underneath the skin of the uterus and they can stick out. And those can be easily addressed with myomectomy. And so those can be good options. Myomectomy can't treat all of the fibroids if you have multiple fibroids, and they have a higher risk of the fibroids coming back. So let's look at some other options. Radiofrequency ablation, they can put a probe into it, heat it, and destroy the fibroid. It can be an option. It's harder to find gynecologists that can do this, but it might be an option for you. It can't treat all of the fibroids, and the bigger they are, it's not very good. But smaller fibroids in certain locations, it can be very helpful. Next slide. HIFU, yeah. So this is non-invasive. There's no incisions or anything. It can be really hard to find places to get this done. And it might be difficult to find reimbursement for this sometimes. And there can be some complication issues, but it can be a good strategy for some people. And then let's talk about next slide. Uterine fibroid embolization. So this is the one that I can offer and talk you through and see if it can be a good match for you. It's an incredibly minimally invasive procedure. Same day, you outpatient, you go home that day. Complications are really, really low and uncommon. They can treat all the fibroids in the uterus. And this is performed through a little small incision, smaller than a pencil. And we introduce a small catheter into the blood vessels, into the artery, and I actually select out the uterine artery on each side. There's a left and a right uterine artery. And then once I get in all the way up to the uterus, I'll release embolics that go into the fibroid and kill them off. The fibroids have an abnormal blood supply, and so they're easily affected by this technique. And the size of the embolics are targeted towards them and don't really hurt the uterus. The uterus is an incubator for life, right? And it has all this incredible blood supply to it. So the uterine muscle can withstand any fibroids that they get. And it doesn't get a lot because I'm actually watching it real time as I'm introducing the embolics. And the fibroids, because they're growing and they're stimulated by hormones, they actually act like little vacuums. So they suck up all the beads that go right into them and kill them off. So they actually help us because they're kind of greedy little pigs. And so they suck up the embolics, which kill them off. And they're really harmed by that. And there can be reasons that they're not affected by that, but that's really uncommon. And so that kind of gets found out when we do the follow-up with our patients, and we can see that. So if you wanted to understand your experience of what that's like, you come in, you get an IV, you go back into the treatment room, we do a nerve block, which helps you get through that first night. And then we'll go in, just like I described, do the procedure, you come back out, the medications wear off, you have a driver to take you home that day. The next day, so we'll give you medications for antibiotics and pain control that will help you get through the next few days. And this technique has been around and it's been described and started in the 90s. I trained in the 90s, and by now, our ability to get you through as an outpatient, all the discomfort from it is really well mapped out. So we can easily kind of do that, and patients really aren't taking any of the pain control medications like narcotics usually after the first few days. And so that's kind of what it's like initially. You can go back to work easily within a week. 1 week if you're doing heavy activities, but light activities, we'll see patients going back a few days later. And then we'll continue to follow you and see that you're not having any trouble and that the technique was effective. And yeah, this is kind of the next slides, kind of talking to you about what that's like. As far as how fast it controls your symptoms, bleeding symptoms are quickly controlled by 3 months. Bulk symptoms are a little bit slower, but we do get there. And there are head-to-head trials with hysterectomy, which do show that we can get the same results. They're just slower when we use uterine fibroid embolization. And then I can see that Maya's trying to make my slides go faster because she thinks I'm talking long and she wants to get to your questions. So I guess if I had to encapsulate it all, I would say that if you don't want the downtime from surgery, you're looking for uterine sparing options that are going to get you back on your feet, have low complications, and are going to get you symptom relief, maybe a little bit slower, but can be done again if for some reason that needs to be done, and are have low complications, then this might be the right choice for you. I wouldn't consider it as a bridge to fertility, but people definitely can have children after this procedure. And so I think we're probably at the end of the educational piece, and I want to get to your questions. So let's try to do that.
All right. So just the first question we have for you, Dr. Conaway, how many times do you have to have UFE? Is it one and done, or is it multiple treatments?
Yeah, so I think it depends on the age. And so all of the fibroids in the uterus at the time of the treatment, um, uh, in large part, and there are reasons that there can be a fibroid that can survive the treatment, but it's pretty uncommon. And so all of the fibroids that are present there almost always are burned out. They shrink, and the active tissue in them is dead, and they just scar up. They don't completely go away, and there's reasons for that I could go into, but they're very technical. And it's mostly because the fibroid actually grows with scar material inside it already. And that scar material that's already inside there doesn't really die and shrink up in of itself because it's kind of already built up is like a keloid or something. But the live tissue, the muscle tissue that's in there will die and shrivel up and shrink. And so that's where all the shrinkage of the fibroids comes from. But it can be quite dramatic in the amount that shrinks. Now, younger patients that get UFE, they can grow new ones. And so those can come back. We don't usually see them within the first 5 years, but after the first 5 years, they certainly, new ones can grow to cause problems. And so that's where we really see repeat treatments or patients that want a repeat treatment. After 40, it's pretty uncommon. And after 45, we just don't see that at all. And that's just because there's not enough hormonal stimulation for them to get big enough to cause patients problems. Because the ones that are going to come back, if you want to say come back, are new ones. So that's a great question.
Okay, another question. Can women still get pregnant post-UFE?
They certainly can. There's lots of data that shows that women can have children after it. Most gynecologists will tell you this is not what you should be having if you want to be fertile. I kind of take it as a little bit different viewpoint on it. There's no evidence that it hurts fertility in a convincing fashion. They will say that there is some data out there that suggests that it is that lowers fertility compared with myomectomy. I think that really depends on what kind of myomectomy you're getting and lots of factors. And that study has a lot of problems. So you definitely can have children after the procedure, but I don't think of it as a bridge to fertility. Usually patients that have fibroids have fertility issues. They're older, so age is already against them. So really, I encourage them and work with them if they have fertility specialists, and I work with the specialist to try to, help them the best that we can. But I don't think of it as a bridge to fertility, but they definitely can have children after it. And that's well shown.
Awesome. Okay, next question. By how much does UFE shrink fibroids? This person was told only by 50%, and so they have a concern for larger fibroids.
Yeah. So, really, there's a lot that goes into that. What I'll tell you is that, so I was telling you earlier about my Scandinavian patient was a horseback rider, avid horseback rider. Uterus came way up into the abdomen, and I successfully shrank her uterus and fibroids significantly. She was able to ride horses again. She didn't even notice her fibroids or uterus anymore, as far as that being symptomatic. Head to head, um, there it shows the same amount of results and happiness from patients as hysterectomy at 2 years. It is slower to get you there, and there's a lot of reasons about that. And really, the shrinkage is not quite related to your symptoms as you think. And I kind of touched upon it. Fibroids grow and they build actually scar material inside them, and so that scar that's actually in the fibroid as it's growing doesn't really go away. It can kind of contract up into a pretty small ball. But in the MRI, because I usually get MRIs on my patients, I can get an indication if there's a lot of that already in there and kind of give you an idea that it may not shrink as much. But we'll see, somewhere between 40 to 60 to 70% shrinkage of these. Now, I'm talking about volume. So often these are measured in diameter, which, when you are, that's what we're really talking about, 40 to maybe 70% diameter shrinkage. But the volume is, when you look at all of those dimensions, the volume is massively shrunk. So when you see MRI images that shows people over time and it shows those shrinking, it's really impressive.
Excellent.
Other
Okay,
questions?
next question. Are fibroids hereditary? Will I pass them to my girls?
Yeah, so there's lots of indications and genes that have been related to fibroids. And, definitely they are hereditary. Unfortunately, 80% of the population is going to develop fibroids. Now, that doesn't mean that they're going to be symptomatic, but I mean, they're found prevalently in humankind. And it doesn't really matter what continent your ancestors might have come from, they're among all races. Now, some get it way worse than others. And so African heritage patients, or they really get them really bad, but others do too. And we see them in all races, though, and they are hereditary.
Okay. Next question. What are the biggest complications or risk of a UFE?
If I was gonna, so they're really pretty uncommon, but I would say that the one that I look out for the most is infection in the fibroids. So we put you on an antibiotic. We talk to you about abstination of certain things. And so trying to avoid that. But, the dying fibroid can get infected. And so sometimes that can lead to hospitalization and IV antibiotics. That's really uncommon, but that's probably the biggest one that, can happen. When you compare that to hysterectomy, though, it's, pretty low potatoes, and all the things that can happen with hysterectomy.
What about pelvic pain? How successful is a UFE in controlling pelvic pain as a result of fibroids?
Yeah. So if the pains are related to the fibroids and not to other things, then it's incredibly successful. Although there's this can be really complicated because I talked about adenomyosis, and this can be really effective for adenomyosis. And adenomyosis patients are my happiest patients that get this treatment. They didn't have to go through a surgery, and their pelvic pain is gone. And they really, really complain about pelvic pain. And so, in that scenario, great. Fibroids, yeah. So, if it's from the fibroids, then it goes back to what I was talking about, that head-to-head study of randomized control trial of patients that went to hysterectomy versus uterine artery embolization or uterine fibroid embolization. Um, the results and happiness of patients got the same scores at 2 years. So it can be really, really effective. It does take longer because um, the fibroids are slower to shrink, and that's what makes the pain go away.
Excellent. Okay, another one that's showing up is, do most health insurance plans cover UFE?
Yeah. Yeah, it's I can't remember the last time I saw that I couldn't get it approved. This has been around a long time. This started out, some of the first reports were many decades ago, but this really lots of the evidence started happening in the 90s, and there's been many, many studies done, and this is widely accepted by virtually all major carriers that I've ever seen. And so maybe there's one that's I've come across that I've forgotten about that was really kind of out of the box, but it is easily approved through insurance.
Awesome. Okay, I know we're getting close to time, so we
Yeah.
will just finish with one more.
Okay.
And you know what, we're gonna go this one. What are next steps if I want to come get checked?
Yeah, so reach out. So I think I don't know that you can see that QR code, but Clarity Care KC, and if you can help us talk about the numbers or ways to get a hold of the clinic, but really contacting our clinic, we walk you through kinds of questionnaires, gathering up what kind of exams or health information that you already have, and so that we don't repeat things. Or if they're more dated, then we might repeat things. But we want to gather all that information up so we can be the most thorough when you come in and see us. And we can tell you what to expect. So our staff is really great at walking you through all that. So really, and I think my QR code is cut off, but
Yeah,
yeah.
you'll be
Oh,
able to see
so
mine. You can
yeah,
scan my QR code.
yeah.
Um, and another option is we are going to send you the recap with this recording in an email. So we'll have all the contact information, and then you can go directly to the website and then refer back to this webinar if you want to rewatch any portion.
Yeah, awesome. Thank you so much for that.
Okay, sorry, we tried to get through most of the questions. If you do have any other questions, though, please reach out to our team. Would love to help you. But thank you so much for your time, everybody who joined tonight. And yeah, hopefully we answered lots of your questions. So
Yeah, well, there's no bad questions, and we love to help patients walk through these options. And so, thank you guys for all being here, and it was wonderful. I know your time is valuable, so thank you very much.
thanks, everyone.
Good night.